Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Today's show is sponsored by the Poway Integrative Medicine Centre, who take a holistic approach to providing the highest level of healthcare, combining internal medicine with alternative therapies, including acupuncture and Chinese medicine. If you're in the San Diego area, they'd love to see you, or if you're in the state of California, they offer secure video conferencing appointments when clinically appropriate. Go to PIMCHEALTH.com or call 858-312-1672. On Facebook, follow Jill Cottel, MD's page. Welcome, Jill. How does it feel to be our first guest?
Hello, Linda. It's very exciting.
Thank you. Could you
Amazing what technology can do.
It is, isn't it? I mean, you out there in the west coast of the US and me in England. Amazing. Could you give us an overview of your LDN experience, please?
Sure. So I've been prescribing low-dose naltrexone since 2008 and have had a lot of success with it. And it's been exciting to watch patients as they respond. And I have a general internal medicine practice, so I get to see a little bit of everything. And so I've had a chance to try LDN out on a number of different clinical situations. And so it's kind of nice to get that, the rounded experience and try it out for different things that aren't, typically used.
Mm-hmm.
It's been interesting.
What would you say the main conditions that you've seen?
I'd say in the beginning, mainly I was treating autoimmune arthritis, just because that was where I was seeing the main focus in a lot of the reading I was doing. And a lot of patients that I had already in my practice had different types of autoimmune arthritis. So that was where I started. And then those patients would refer other patients. And then I started branching out. And then kind of it's a mix past that. I have a lot of patients with fibromyalgia or just muscle-type pain, and then different types of chronic pain syndromes, and then just a wide variety of other things, asthma and allergies, some neurologic issues.
Mm-hmm. One of the questions that people like to know before they start is, what are the side effects likely to be? Have you noticed any side effects?
Well, it's really well tolerated. When you compare it with just about anything else that a doctor would prescribe, all day long we write prescriptions for various things for high blood pressure and diabetes and high cholesterol. You look at any one of those number of things and pull out the prescribing information, and it can boggle the mind about the list of things that can happen. And so when you look at low-dose naltrexone, very, very minimal side effects, a really good profile. I would say when people report a side effect, it usually has to do with sleep. And I would say really in my practice, that's really only maybe 10 to 20% of the people will have maybe sleep interruptions or vivid dreams. And sometimes that will pass and sometimes not. If it is an issue, they can always move it to dosing at a different time of day, and that will usually clear up the problem. And aside from that, pretty uncommon. I've had maybe in the past couple of years a handful of patients who've had kind of a strange headache, and that usually passed within the first week. And then some patients who their stomachs are very sensitive. In the beginning, they might get a little bit of loose stool, but again, that tends to be just in that group of patients. And even that will generally pass after the first week or so. So not a whole lot to report.
What drugs can't you take alongside of LDN?
Basically, it's the narcotic-type medications. So things like oxycodone, hydrocodone, morphine, those sorts of pain medications. Other medications for pain like Tylenol and ibuprofen and those sorts of things are fine. There's really a wide variety of things that can be taken with low-dose naltrexone, and in the way of drug interactions, I haven't seen any problems except with the narcotic-type medications.
Because I know there have been people who've asked questions about methotrexate, interferon drugs, steroids, and I believe all of those can be used with LDN.
Right. In my practice, I've not had any issues, and I know there are a number of other clinicians using them together and haven't reported any problems. So there's some good experience there.
What would you say has been your greatest success with LDN? Do you have
I would probably the autoimmune arthritis patients. And those are the most fun because often they respond really dramatically and they'll respond very quickly. And that's exciting to see when that happens. So I'd have to probably that. The fibromyalgia patients, every now and then you'll get someone who responds really quickly and a complete response, and that's exciting too. Doesn't quite happen quite as often as the other ones. Those have been fun.
It's amazing, isn't it, that you can get people on very, very strong painkillers where it doesn't control the pain. They come off them, try LDN, and they're suddenly pain-free. It always astounds me. That's such a small pill.
Yeah.
You know, it's like using a sledgehammer and it doesn't work, and you tickle it with a feather and it does. Exactly.
One of my first patients who came off large doses of pain medications this a few years back, he was on, I want to say, almost 100 milligrams of oxycodone or something similar, and wanted to try LDN. And I thought, well, this is just no way this is going to work. And he tapered off on his own. And then, and by the way, the 100 milligrams hadn't been controlling his pain was the whole problem. And then he was completely pain-free on 3 milligrams of LDN. And it was amazing. It worked. How can 3 milligrams of LDN work better than 100 milligrams of oxycodone? But there it was. He was pain-free. It was amazing.
Always amazes me too.
When you think about some of these studies showing that the narcotic medications can actually cause hypersensitivity to pain and possibly, central pain. Look at it that way. Well, maybe it makes some sense that patients are going to do better off of those medications and on LDN.
I've also been told that if you take a cocktail of pain medications, you can then take too many and then they don't work either if you're taking too many pain medications. So that's interesting as well.
It's hard to sort out because often if you have patients with chronic pain, they'll come in and they'll be on, a lot of different types of medicines from different classes, usually all off-label, because everyone's trying to help them. And it's hard for those patients. They've got a lot of side effects. And when you can start getting them off of those medications slowly, then on LDN, they start responding. You can start weaning off some of these other medications. A lot of the medications that we use for chronic pain have so many side effects. And so people tend to feel a lot better being able to come off of them.
That's good. Okay, well, we'll take a break now. And when we come back, we'll take callers' questions. Today's show is sponsored by the Poway Integrative Medicine Centre, who've taken a holistic approach to providing the highest level of healthcare, combining internal medicine with alternative therapies, including acupuncture and Chinese medicine. If you're in the San Diego area, they'd love to see you. Or if you're in the state of California, they offer secure video conferencing appointments when clinically appropriate. Go to PIMCHEALTH.com or call 858-312-1672. On Facebook, follow Jill Cottel, MD's page. Welcome back. Now we've taken our first caller. We've got Blanca. Hello, can you hear us, Blanca?
Yes, thank you so much. I am here.
Okay, what question would you like to ask Dr. Cottel?
Oh, okay. Doctor, thank you so much for listening to my question. Did you have any experience with multiple myeloma? It's a bone marrow cancer. My husband has it, and we have been taking low-dose Naltrexone. Well, he has been taking it every day for 4 months, and we have seen his numbers stable. We haven't seen like a reduction. So I was just wondering if you have any experience with multiple myeloma.
Not so far, but that's a great question. I would expect, based on the positive results that other people are getting with different types of blood disorders, that would be something that could be beneficial. And you said that his numbers have been stable over the past 4 months?
Yes, stable. He has. He's not using any chemotherapy for now. He used chemotherapy back in 2013. I heard about low-dose Naltrexone, but actually I wasn't sure where to get it or which doctor will give it to me. So finally, back in April, we got a prescription from a doctor, and he's been taking it since maybe 6 months already. Time flies. So it's been 6 months, and I've noticed that he stopped taking it for like 3 weeks because he developed some anemia because of a nosebleed. And we were afraid of any interactions of any of the supplements, so we stopped the low-dose Naltrexone. And I've noticed that his numbers raised a little bit, so we went back right away to low-dose Naltrexone, and the numbers went back to a little like lower, but stable. But it's not like a huge change, like remission or something. But at least it's keeping the cancer at bay. Yeah, I'm sorry.
Oh, I was going to ask, how does he feel on it? Can he tell a difference taking it now versus when he wasn't taking it?
No, not at all. He doesn't feel anything. He has the sleep problems since many years ago. He has the sleep apnea, but I have noticed that he's not having any episodes of apnea anymore. And I've noticed that he sleeps deeper. He wakes up because he has that problem from before, but I think his apnea is not as acute as it was before. I think it's helping like to get more like deep sleep.
Well, that's good. That's good. I've had some patients report that they feel like they're sleeping better on it. Their quality of sleep improves.
Yes, exactly. And sometimes I wasn't sure if he has a little bit of anemia, if it's okay to take low-dose Naltrexone or with Tylenol, but I heard Tylenol is fine.
Yes, that would be fine. That'd be fine.
Yes. And having anemia, do you think there's a problem?
No, I can't see any reason why that would be a problem with anemia.
Okay. That was the only concern, because his doctor was maybe thinking about introducing a very, very low dose chemotherapy capsule. So I wasn't sure if it has any interactions with chemotherapy or immunosuppressant or regulator.
I don't have any experience in patients specifically with multiple myeloma, but I've had other patients where I've used LDN in combination with immunosuppressants, and we haven't seen any problems.
Oh, okay. Okay, perfect.
Okay.
Thank you so much.
Well, thank you. We will get to our next caller now. The next caller is Saber.
Hello.
Hello.
Talking to me?
Yes, that's fine. I thought I cut myself off. So next we've got Saber. Hello, Saber. Can you hear me?
Hello, yes, this is Saba.
Hello. What question do you have for Dr. Jill Cottel?
So I'm a pharmacy student, and I just learned about LDN and how it works, and I'm really interested to know more. And I just wanted to see if the doctor can explain to me the exact mechanism of action and what's happening with this medication. I kind of know, and in pharmacy school I learned that it's mostly used for alcohol dependency, but they never talked about other indications for low dose in naltrexone. So I just wanted to see if the doctor can explain more about the medication.
Yeah, I'd be happy to do that, and that's a great question, and I'm so glad to hear as a student you're looking into it. It's exciting, and especially from a pharmacology standpoint, this is a fascinating compound. There's more information if you want to look the level of this that would probably interest you. There's an article that was published in 2014 in Clinical Rheumatology, and the lead author is Jared Younger, Younger, and you can actually Google this line and pull it up. But the title is The Use of LDN as a Novel Anti-Inflammatory Treatment for Chronic Pain. And that article is pretty straightforward. It's easy to read, and it outlines different pathways and receptors. And then also in the LDN book, which just came out this year, the first chapter is by Dr. Stephen Dixon, and it goes over the pharmacology of LDN in detail also. But there's several different ways in which we think it works, and it's interesting because this chemical is a mixture of both a left-handedness and a right-handedness. As you've probably seen this already in school, a number of these medicines that we use are like that. And so the left-handed side does a number of things with different receptors that have to do with inflammation. And then the right-handed side has to do with the effects that it has with opioid receptors, which might be in more detail than we need for our other listeners. But I would encourage you to look at those two resources because it's very, very interesting. There's a lot more research about how low-dose naltrexone works than many, many other types of therapies that we have for pain.
Okay, thank you so much.
Thank you.
You're welcome.
We'll go to our next caller now. And our next caller is James.
Hi, James.
Hello, James. What question do you have for Dr. Jill Cottel?
I've been taking low-dose naltrexone for 27 months now. I began taking it for non-Hodgkin's follicular lymphoma. And I'm almost 70 years old. I feel like I'm 50 years old again.
That's wonderful.
It cleared up my depression. It cleared up my brain fog. It cleared up my fatigue. I'm physically about twice as strong as I was. I've always done, I've done heating and air conditioning work. And I'm actually back doing heating and air conditioning service work now.
That's fantastic.
But it cleared up the ringing in my ears that I had for years and years and years. But anyway, my question is, after taking 4.5 milligrams for 27 months, I was wondering if I should, I've been reading more about dosing and scheduling, and in this last research trust documentary, they talked about dosing, different dosing protocols. And I was wondering if you should, if someone was taking it as long as I had, should like get off of it for a few days and then take it, not take it every day, 7 days a week. If I should skip a day now and then, or skip a couple of days every so often, if it would help.
That's a very good question. I know that Dr. Danglish in London is looking at this. Linda, is that correct?
I'm sorry.
Linda?
I was reading. What was the question?
Okay. Dr. Danglish, he's been looking at dosing studies for cancer patients.
Yes, he has. Yes, intermittent.
And so this has been
dosing.
something we're looking at as to whether continuous versus intermittent therapy for cancer.
Mm-hmm.
And from what I had gathered, it seemed like when you were in the treatment phase of the disease, it was continuous.
Mm-hmm.
And then off somewhere in the distant future, if you were in remission, you would maybe fiddle with the schedule a little bit. But I would say that for lymphoma, I would probably continue taking it daily. But I'm not the most experienced person for oncology with it.
Yes,
Linda?
we will have Dr. Akbar Khan in a few weeks, and he'll be talking about cancer. So maybe you'd like to call back, James, and ask your question to Dr. Khan.
Well, I will, and thank you so much for all the good work that you've done. It's LDN has just really given me my life back, and I feel great. I really appreciate all you do. Thank you.
That's good to know. Thank you. We'll go to our next caller, and our next caller is Harry. Just one moment. Let's just find Harry. Hello, Harry. Are you there?
Yes, ma'am. I'm here.
What question would you like to put to Dr. Jill Cottel?
Well, more than a question, really, I don't have a question. Mine is a bunch of attaboys for the work that you people are doing. And mine is a real success story with LDN. I had ulcerative colitis onset after a bunch of cath heart work about 15 years ago. And for the first 8 or 10 years after that, I was being given everything you could think of, 5,600 milligrams a day of malsalamine, Imuran, 50 milligrams of Oxy a day, which didn't solve my pain problems, which nobody could figure out.
Mm-hmm.
And we finally, through Dr. Julian Whitaker, we got some information on low-dose naltrexone and started reading up on it, and finally found a doctor who would prescribe it. And basically, with me, we went no dairy, gluten-free, making Rejuvelac for me, for my probiotics, and 4 milligrams of LDN a day, and I had results in less than a month.
Oh, fantastic.
And I have been, the doctors, all of the, I will say normal doctors, not like the extremely, I think, intelligent doctors we're dealing with here, but normal, or abnormal if you want to look at it that way, doctors, all of them would admit that there was no way that LDN could possibly hurt me, but none of them would prescribe it, but they did want to take out my colon. Well, last I heard, that doesn't grow back, so that didn't seem like a good idea to me. And literally, they will now, and the last scope I had was in August, and for a while they were doing scopes when it was so bad, they were doing scopes on me literally every 4 to 6 weeks.
Wow.
The last one I had here this last August, they again, the gastro doctors will say, no evidence of active disease. They will say quiescent ulcerative colitis. They just won't admit it's gone.
That's fantastic.
Literally at this point, I have no dietary restrictions at all. I have gotten completely off of that. I just take my 4 milligrams of LDN every night, and I eat anything and everything and have zero problems.
Wonderful.
So I would just encourage anybody who has not found a doctor where they can talk to them about these problems and can maybe get something that is, quote, off-label, to do so, because at the very least, if all of the doctors admit that the LDN can't hurt you, it would seem to me that it would be advantageous to at least try it.
Right.
For some of the more drastic things. And I mean, they had me on, of course, on the Imuran and, you know, all that kind of stuff. And none of it worked. And there's some really nasty side effects to some of those drugs they use, just like with chemo drugs. So mine is just a good story. And I realize it may not work for everybody, but it's certainly worth trying.
I agree.
One quick aside on the pharmacology student that called a while ago, one of the things, and I made a CD up of LDN research stuff, and I keep adding to it as new stuff comes out, and I take it to every doctor I go to. One of the things that's on there is, if you go out to YouTube and you Google, or not Google, but search on YouTube, there is a video out there called Ldn How It Works.
Ah.
And it is only, I'm thinking 13 minutes or something like that, either that or less, which talks very specifically about how this works at the neuron level. And it's an excellent little video. It's not all hard to understand medical stuff. It's something that a normal person can understand. And it's very, very informative. So that might be something for the pharmacology student to go take a look at, and anybody else who wants to know. But that's all I had to say, was just it works. It's worth doing. We need to try and get as much information out to everybody we can about this, because there's so many things that people are taking that are so terrible on their system, and then they don't work.
Yeah.
Okay.
So that's all I had. I do appreciate y'all's efforts. I appreciate the time. I'll hang up and we'll listen to somebody else.
Thank you, Harry. Well, we'll go to our next caller, who hasn't left their name, so we'll have to see if they're still there. Hello, can you hear me? Hello?
Hello?
Hello. Would you like to ask a question to Dr. Jill Cottel?
Oh, are you speaking with me?
Yes, I am.
Oh, good.
You
okay,
didn't
my
leave
name
your
is
name.
Teresa.
Oh, okay, Teresa.
Oh, I did. Maybe it didn't register. Yeah,
Okay.
I thought I did. Or maybe I need more LDN. It has been wonderful. I have been taking it since May. It has helped me tremendously. Unfortunately, it hasn't 100%, maybe 80-85%. But I do understand that it doesn't correct things that have been of an old issue. So maybe I didn't catch my problem in time, but I was able to find my doctor who wasn't familiar with the medication, but he did allow me to try it, fortunately, thank goodness. And it's been wonderful ever since. So, but it hasn't corrected everything, so I still look at a couple things, and I'm looking at something called S-adenosyl methionine, which is SAMI. It's an amino acid, and it does supposed to help with arthritis and other issues, but my concern is with stiffness. And so I'm wondering, will it affect that? I know it affects your brain, the SAMI, and the LDN also works in the brain with the enkephalins and the I'm getting mixed up, the metenkephalins and the endorphins. And I don't know if that would be an issue with mixing those together or not. And if then there's the other issue, which is Wilson's temperature syndrome, which may be an issue with me. That may be my problem. So everything combined, because it's all working in your brain, would it be a problem mixing all this together? Or
that's a good question, because I often will have patients and they'll be taking SAMI, and then we'll start an antidepressant if we're treating them for depression or something. And then it's important to know what herbs and supplements they're on, because not everybody will bring that up. And so there are some interactions with SAMI and different types of antidepressant drugs. So this is a good question, because we do know that low-dose naltrexone has some interactions with the different neurotransmitters, but it's so mild in terms of the effects with LDN that you should be fine taking it with SAMI. Actually, I do have one patient who is taking SAMI with the LDN, and she actually did better with the combination than she did with the LDN by itself.
Oh, wonderful. That's great to know. Now, my other concern is that we haven't looked into this part yet, but because my issues have been so evasive, that it may be Wilson's temperature syndrome. So we may be going down that road, looking at certain protocols that may require some cytomel for a small amount of time to regulate the body temperature, and this may resolve, a lot of my issues. But is there any complication with using LDN and the cytomel and maybe the SAMI? I also use ashwagandha, which is also as I understand, I think it's an acetylcholinesterase inhibitor. So combining all those, I mean, I don't know what I'm doing. but I do know I feel so much better, but I don't want to pose another problem that may be worse down the road. So there would be the cytomel and then the ashwagandha and the SAMI. So
the ashwagandha should not be a problem. The cytomel, just be very careful with that, because some people will respond fairly dramatically to cytomel just on their own when you're treating them for low thyroid, and sometimes it's difficult to get the thyroid adjusted with that. So I would say dose it talk to your doctor about dosing it very low and very slowly, and watching your thyroid numbers pretty closely. I would say getting them checked at least within the first 6 weeks of starting it.
Oh, yeah. See, he's really unfamiliar with the LDN, but and my thyroid numbers are always fine. But with Wilson's temperature syndrome, the thyroid numbers are fine, but the T3 can be also fine, except the low body temperature is always low. So this is an indication of it. And then you have all the, chronic infections and, pains and all that. So this is going by the symptoms. So this is another type of protocol where it would just be very slow. So then it can be done, because he's not familiar with the LDN, like I mentioned, but it can be mixed, but very, very cautiously, right?
Exactly.
Okay. So I guess I'm going to have to keep I'm going to have to keep on top of it myself, because since he's unfamiliar with it, I'll have to be a better judge with my own feelings. Okay. All right. Well, gee, I appreciate your time, and thank you for getting LDN out there, because it's been wonderful. I heard about it about 4 years ago, and I was thinking, how do I ever get that? And then I was so lucky to have a compounding pharmacy online broadcasting it, advertising it, and it was in my area, so that got the news out. So it's wonderful that the news is getting out, and more people are going to be able to be a little bit less painful.
Okay, well, we're going to have another break, and we'll be back with some more questions later. Today's show is sponsored by the Poway Integrative Medicine Centre, who've taken a holistic approach to providing the highest level of healthcare, combining internal medicine with alternative therapies, including acupuncture and Chinese medicine. If you're in the San Diego area, they'd love to see you. Or if you're in the state of California, they offer secure video conferencing appointments when clinically appropriate. Go to PIMCHEALTH.com or call 858-312-1672. On Facebook, follow Jill Cottel, MD's page. Welcome back, and this time we're joined by Cynthia. Hello, Cynthia.
Hello.
Hello.
Hi.
What question do you have for Dr. Jill Cottel?
I have PMR for the second time. I have been using LDN since July 2015, And when it came back again this July, it was significantly less pronounced than the last time. However, I'm not on steroids yet, and I'm trying not to. I'm doing everything I can with a low inflammatory diet, etc. But if things get worse, is it all right if I do go on to steroids? Also, there's a possibility I might be developing giant cell arthritis because I have a very painful jaw and sort of extreme tenderness around the hairline and the top of the head, but no headaches yet. Last time I was probable GCA, but I've been in touch with my rheumatologist just yesterday, just in case they want to do a biopsy. But I really want to know where I stand vis-a-vis LDN and steroids.
That's a very good question. If you were just dealing with the PMR alone, that would make it a little bit easier. And definitely it would be fine to combine steroids with the LDN for PMR. I've had patients do that. And you can generally get away with using less steroid and come down off of it more quickly. But if there's any possibility of the temporal arteritis, you have to be more careful about that.
I realize.
Because of having your vision affected.
Yeah.
So I'd be more vigilant about that and getting your eyes checked frequently and making sure they are watching you closely.
Yes. So
if that weren't an issue, it would be much more easy.
Well, I'm hoping that I haven't got the GCA. I'm really hoping. But up to what level can I take steroids? 25, because I know that with CGA, they will often, GCA, start at 25 milligrams, the steroids. Is that all right with LDN?
It should be fine.
Oh, great. Mm-hmm. I mean, I'm hoping not to, because last time I was on steroids for 3.5 years, and then I was on methotrexate as well for the last year, probably.
Uh-huh.
And I didn't like either of them, with all the side effects that combined. So I'm hoping to keep off the steroids. I just wanted to know where I was, because I'm hoping to see my rheumatologist, who will obviously know nothing about LDN, and I wanted to go with my armor, so to speak, ready, and be able to tell him what was what.
Sure.
Okay. Well, good luck with that.
If I thank you so much. Thank you.
Yes, okay.
Dr. Cottel, and thank you for all your good work.
Thank you.
Bye-bye.
Bye-bye. Okay. Next we have Glenda. Can you
would it be Linda?
Yes, it is. Hello, Glenda.
Linda. Yes, my name is Linda Hines. Uh-huh.
Oh, Linda. Oh, it says it's come up as Glenda. So you're Linda, sorry. Do you have a question?
Yes, ma'am. Yes, I do. I have severe Crohn's. I've had 3 bowel resections, and the last one I ended up with a hospital bug on a ventilator for 2 months and almost died.
Wow.
So it's very, very important that I take my LDN all the time. I've been on it for about 6 years. But here's my problem. Now that they look in my colon and they go, oh, you're basically in remission. There's nothing going on in there. It looks beautiful. Now I still can't control the bowel movements and the diarrhea all the time, but it's better than it used to be.
Mm-hmm.
Okay, here's where it gets complicated, though. I also have multiple pain issues, fibromyalgia, myofascial pain, stenosis, and the like in the spine. And I've had to have my ureters replaced with tubes that have to be changed out every 90 days or so.
Goodness.
I have not been able to let go of my pain medication, Dr. Jill.
Huh?
And what I eventually did was worked out a plan for myself, because I couldn't get anybody to do it with me, where I do not take a pain pill of any sort after 3 p.m. in the afternoon. And when I go to bed at 10 or 10:30, I take my LDN. And I feel like most of that pain medication has left my system. Do you see a problem with that?
I don't. I mean, if my patients are on pain medication and they're taking it so frequently that they've always got some in their blood, that can be a problem. So even if their last dose is at 3, if they've already taken, a certain amount of medication that day already, it may not be completely out of their system by bedtime. But if you're on a small enough amount that you're getting enough space out from it, you should be okay. And if you weren't, you would probably know immediately anyway.
The other thing would start happening again.
Right. Pain would come back and you get some withdrawal symptoms. There's the issue, of course, your chronic narcotics, hyperanalgesia, the central nervous system pain effects from being on them. But like you were saying, it's risk versus benefit. And with all the different pain type syndromes you're having, if it's something that you aren't able to come off of, then, have to just do your best.
I have tried, and it just has been impossible for me. I end up becoming homebound and in bed, and I refuse to accept that.
Good.
And I fight it as hard as I can. So I take the minimal dose the earliest possible during the day, and then just do the white knuckle teeth gritting when it gets to be later in the day, so that I can have my naltrexone at night. And I think it's working because my colon is still beautiful.
That's wonderful.
Okay. I so much wanted somebody to tell me if that was an acceptable way to combine them or not. So thank you very, very much.
You're welcome.
Thank you, Dr. Jill. Thank you, Dr. Linda. Bye-bye.
Bye-bye. Oh, I'm not a doctor, but never mind. And next we have Mary. Hello.
Oh, hello.
Hello.
Can you hear me?
Yes, I can.
Oh, I'm so sorry. I tuned in late, so I'm not sure of the prior conversations, but I have been looking at LDN for a long time, and I haven't gotten a doctor to prescribe it for me. I had asked a couple doctors in the UK. We lived in Sweden for 3.5 years. And I went to the UK for treatment with bioidentical hormones. And I asked the doctor there to prescribe it, but she wouldn't. She just didn't think it made any difference. But she said she didn't believe there was any research that proved that it would help. I've gone to the seminar. I listened to it at home. I think it was in Las Vegas one year, and I thought that it would help me. I currently am not taking much pain medicine. I take Arthritis now and then. I have fibromyalgia. I have chronic fatigue, and the fatigue is bothering me much more than the pain is now. Do you think LDN would help me?
I do. Based on my experience with my patients who have fibromyalgia and chronic fatigue, for the fibromyalgia, almost all of my patients have had some benefit, but a very few have not. Almost everyone has had some. And then I've had patients where they've had dramatic improvements with the fibromyalgia. And same thing with chronic fatigue. Most of my chronic fatigue patients are feeling much better. So that's one of the things that we do have a good couple studies looking at fibromyalgia with low-dose naltrexone, and you should be able to find someone to prescribe that for you.
Now we just moved about 2 weeks ago to Austin, Texas.
Uh-huh.
Do you know of any doctors in this area that are familiar with it?
We have a list, and there are some doctors around that area. If you would like to send me an email, linda@ldnrt.org, and we will get back to you with some of the doctors that we know of that prescribe.
Oh, that'd be great. And you said
linda@ldnrt.org.
Okay, perfect.
Lovely.
That's perfect.
And we will
Thank you
quickly
so much.
get to the next person. So thank you very much, Mary, for your call.
Oh, thank you.
Thank you. And our next caller is Robin.
Hi there.
Hi, Robin.
Question regarding chronic fatigue. Hi.
Hello.
Can you hear me? Yes. Hello.
Hello.
You just answered part of my question about chronic fatigue syndrome, but I wanted to be a little bit more specific. My son, who is 18 years old, has been suffering with CFS for about 2 years. He seems to be improving with nothing, I guess. He's on an antiviral that doesn't seem to be helping to me, but he's just gradually getting better. And specifically, do you think that it would help his, like these setbacks and crashes that he has that we're trying to really put an end to? I mean, what specifically with CFS does it seem to help other than just the fatigue?
I would say probably energy improves, and also a lot of times mood improves. And so patients, sometimes the symptoms aren't as much improved, but their ability to cope with the symptoms is better. Does he have any muscle-type pain at all, or is it just the fatigue?
He really doesn't have muscle pain. If anything, he has suggested that his limbs feel heavy at times. He occasionally has a headache, but not often. It really just seems this excessive fatigue. If he doesn't get enough sleep, if he it's stress and emotional stress or concentrating in school that seems to cause these setbacks the most. Mm-hmm. And then he can't, basically get off the couch for a couple of days.
Uh-huh. Well, I would think it'd be worth trying.
I agree. Okay. I just wanted to confirm because I hear it used more with pain and fibromyalgia, but not strictly with chronic fatigue syndrome. So I was just wanted to confirm it's worth the try.
Yeah, I think
thank you very much. I appreciate your help.
You're
enjoying
welcome.
the show.
Thank you.
Bye-bye.
Okay. We have got one or two questions that I said that I would ask. And Sarah on Facebook wanted to know if you'd had any success with LDN for treating Epstein-Barr.
Yes, I have a patient who she had illness with Epstein-Barr, and she just hadn't been able to bounce back from it. And it had been, I'm going to say, at least 6 months, and she started taking the LDN. And I want to say within about a month, she was feeling much better. And then it wasn't much longer after that. She kind of felt back to normal. Mm-hmm. So at least one patient there.
Okay. And Liddy said, can LDN be taken with high doses of manganese?
I don't see any reason why not. From the little I know about manganese.
Mm-hmm. Okay. I've got so many questions here. How does LDN help with adrenal insufficiency?
That is a good question. I don't know the answer to that. I do have patients who've come in with the diagnosis of adrenal fatigue, which is kind of a nebulous sort of thing. And I'm not sure anyone knows why LDN helps those patients, but it might just be the endorphins themselves helping with energy and mood.
And a question. We've got many Sarahs, and this one is asking, is endorphin build-up a real thing, and should people occasionally skip a dose? And if so, how often?
The patients that I've had, generally when they skip doses, they feel worse. And sometimes not right away, but they can usually tell a difference sometimes after 4 or 5 days off. I think in general, probably not skipping doses. And you figure it takes a while for the endorphin levels to decline anyway, so how much difference you're making just by skipping a day or two here and there, probably not making too much of a difference.
I must admit, sometimes I'm just drifting off to sleep and I think, oh, I haven't taken my LDN. Do I get up and take it and wake myself up, or just miss a dose? And I sometimes miss a dose and it doesn't make any difference. But yeah, I think sleep sometimes is better than getting up and not going back to sleep.
Yes.
Another question here from Kaylin. Does LDN stop progression of a disease? In her case, she's got rheumatoid arthritis.
That's a good question. I don't know that anyone knows the answer to that for sure. I think that we look at terms like remission and how people are doing clinically.
Mm-hmm.
So, I mean, it's just a matter of semantics, whether you say, it stopped progressing or it's in remission. We go by how the patient is feeling clinically.
Okay. And another one there about dosing. The benefits of splitting the dose into 2 over a day for CFS-ME.
So, again, that's a very good question. I generally discourage my patients from doing that just because that's not the way it's classically been dosed, and it's not the way it's been dosed in the small studies that we've had. And one of the mechanisms of action is to briefly block those endorphin receptors, and it has to be brief and it has to be in and out of your system. So what the implications would be of doing that again only 12 hours later, we don't know. And naltrexone has metabolites that stay around in the body afterward. So I would tend to discourage it.
Mm-hmm. Okay, we've got time for one more caller who hasn't left their name. Hello, can you hear me? Hello?
Hello?
Hello there. Would you like to
Hi,
ask?
this is Phyllis.
Oh, hi,
and I did
Phyllis.
leave my name.
Oh, it didn't come up as Phyllis. Very sorry. What question would you like to ask, Jill?
I would like to ask for a group member who has been trying to get an answer to this question, if Dr. Jill has ever treated or know of anyone treated for a condition called stiff person syndrome, also known as stiff man syndrome. And, well, I'll start there, and then there's a part two.
That doesn't sound familiar. Is there anything else that goes by?
No, those are the only 2 that he stated and that I know of is stiff person or stiff man syndrome.
That is
it's pretty rare, I believe.
It is actually on our list of conditions that LDN can treat.
Okay.
I'm looking at it just in front of the computer since I'm sitting here, and it says a rare neurologic disorder of unclear cause with progressive rigidity and stiffness, mainly affecting the trunk muscles with spasm. So, no, I don't have any personal experience.
Okay.
Well, then the second part, really, he's wondering if if you knew of anyone, if they had shown improvement. Right. He's hoping he's on LDN and he's taking it, but he was...
I'm really going to have to stop you there, Phyllis.
Okay.
When the hour's up, we stop. So I'd like to thank you very, very much for taking our calls, and thank you, Phyllis, for calling in.
Thanks, Dr. Jill.
And,
yes, you're welcome.
You were amazing as always, Jill. And next Wednesday, we'll be joined by Dr. John Kim, even. And full details are on the website. Thank you. We would like to thank today's show sponsor, Dr. Jill Cottel and the Poway Integrative Medicine Centre.